So now it is my pleasure to introduce this year's speaker, Dr. Jeff Blackmer. Dr. Blackmer is no stranger to Saskatchewan, as he completed his residency program in physical medicine and rehabilitation at the U of S. He holds a master's in medical ethics from the University of Toronto's Joint Centre for Bioethics and currently serves the Canadian Medical Association as the VP for Medical Professionalism. In 2012, Dr. Blackmer was a recipient of the Queen's Diamond Jubilee Medal for his contributions to the field of medical ethics and international medicine. And more recently, he was the recipient of the 2017 flu shot, if his Twitter account is to be believed. So please join me in welcoming Dr. Jeff Blackmer.
Thank you. Thanks very much to St. Paul's Foundation for the support in having me be here today. And this place holds a special spot in my heart. I spent 6.5 years here, and I still come back as frequently as I can. Thanks as well to some very old friends and colleagues who have joined us today. And thanks to all of you for taking time out of your busy schedule to talk about something that certainly is near and dear to my heart in the area of medical ethics. And I think these are issues and these are things that we all deal with on a day-to-day basis, and it's nice sometimes to sort of take a little bit of time to reflect on these things in our very busy clinical lives. So I'm going to talk a little bit about this whole concept of what happens when good people disagree, what happens when our morals don't always align, why does this happen, and what can we do about it? So I'm going to provide a bit of an overview on the concepts of morality, and particularly from a very practical standpoint, how do healthcare providers understand what we mean by morality, and how do we apply that in our day-to-day practice? I'm going to unpack this issue of conscientious objection, which is something that's really been at the forefront of a lot of conversations around assisted dying in particular. And then really dig a little bit into that area, because I think it's a really great illustrative example of these challenges that we sometimes have at the team care level or at the individual patient level in figuring out how our own personal moralities interact with the laws and regulations and codes and help determine how we are going to get along with our colleagues, get along with the patient and their family. And it's really forced us to have some difficult, but I think really important and in the end, I think ultimately really successful conversations around these issues. So in many ways, regardless of your sort of views or beliefs on the whole concept of assisted dying, I think it's a good thing that it's made us confront some of these challenges that we have in a way that we really haven't up until this point. We've sort of let things sort of grumble along, I think. And then I'll talk a little bit about some approaches or some ways of thinking about resolving some of these moral dilemmas in the team context. Obviously, I don't have any answers for you today. If there were answers, we wouldn't be having this conversation. We'd already So a lot of this is really ways of thinking about these things and some ways of approaching it. And I'll certainly leave some time at the end. I think one of the best things in this area, or the most important thing, is the opportunity to dialogue and to share experiences. Because so much of this, when we talk about sort of moral ambiguity in the team context, so much of it is experiential and comes down to examples that we've had and challenges that we've had and things that we can learn from that so that we try and avoid those pitfalls next time. So before I start, I'm going to ask everyone, and be honest, how many of you in this room think that you have a reasonably good sort of moral compass or sort of internal sense of personal ethics? Okay, I'm just going to say that's everyone. How many of you work in a profession, a healthcare profession or other area where you have some kind of a code of ethics or a sort of a standard that sets expectations for ethical behavior? So most of you. Okay. How many of you have had a challenge in terms of moral disagreement with a member of your team? And it doesn't have to be a big one. Okay. So I'm going to pretend that everyone raised their hand to all three of those questions because most of you did. And I think if you think about that, you'll see why it is that we're talking about this. So we all have, and I believe it to be true, a reasonably good sort of internal ethical compass. We're all relatively senior in our careers. We've seen a lot. We sort of know how these things work. Most of us have a standard of expected behavior, regardless of what that sort of looks like. And yet still, we struggle with these issues. Those things aren't enough. So let's talk about why those might not be enough and what we can do about it. Sound okay? All right. So I'm going to give a few areas of example because I don't want people thinking this is all about assisted dying. It's really not. And I'll give you 3 examples, but we can all think of probably hundreds more. So the family of an 83-year-old woman with advanced dementia requests insertion of a feeding tube, and the team has to talk about this and decide how they're going to approach this issue with the family. Right? So you can imagine different viewpoints amongst team members. Maybe the speech therapist feels differently than the occupational therapist, who has a slightly different view than the nurse, and the physician feels a little bit differently than all of them as well. Right? So different perspectives on a common, complex issue. A young woman with 3 male children requests IVF and pre-implantation genetic analysis to help her conceive a daughter. So she wants to have a little bit more balance to her family. She wants to go through expensive technology to help her with that. Some people might feel this is a very legitimate use of this, and in fact it happens in Canada. Some people might feel this is ethically problematic for a variety of reasons. So how do we as a team, when we're approached with this request, how do we as a team talk about our different positions and our different views? And then finally, a 55-year-old male with terminal cancer requests access to medical assistance in dying. So I would say, and you will all feel slightly differently about this, but I would put it to you that there are not necessarily any right or wrong answers from a global perspective to any of these cases. There are different perspectives, and there are different perspectives that you as individuals will feel are right or wrong for a wide variety of reasons, whether that's your internal moral compass or the way that you've approached these issues in the past or what your code of ethics says. There are different ways of approaching this as an individual team member, but you will find that other team members may have different points of view that they hold to be equally right or wrong in that particular situation. So how do we know? We'll just take a little bit of a step back. How do we know what's expected of us from an ethical or moral standpoint? So how do we as healthcare providers sort of arrive at a conclusion on the right or wrong course of action? And there's a variety of ways that we do this. So professional codes of ethics, and I'm going to unpack this a little bit because for a lot of us, this is really sort of the standard, the guide that sets expected standards of behavior. And most healthcare professions, particularly regulated healthcare professions, do have a code of ethics. And the way that these are developed says a lot about that profession and about the expected standards of behavior. And I've been privileged to participate in the development of codes for a number of different professions, for nursing, for a number of the therapies, for dentistry. Just in case you thought your dentist was unethical, there are codes of ethics for dentists as well. Although, having said that, my father was a dentist and my mother was one of his patients, so maybe back in that time it wasn't as stringent as what it is now. There are institutional codes of ethics and professionalism and conduct, and we're here in a faith-based facility, and so the expected standards of behavior at St. Paul's might be slightly different than they would be in a non-faith-based institution. So the way that we approach some of these issues might vary depend on where you're practicing, right? So we have to keep these things in mind as well. Same thing for example, a teaching hospital. So I do a lot of teaching at the University of Ottawa, and the university itself has standards of professionalism and behavior that they expect of their students, regardless of which facility they're practicing in. So there's all these different policies that tell us what we should and shouldn't be doing. And then if we're a member of a regulated profession, it's really important that we know the college guidelines or policies, because these are the people that decide whether or not we're going to have a license and be able to practice our career and put food on the table. So we have to be very aware of what our regulatory bodies say as well. And the graphic here is from this magazine called Dialogue, which is the magazine I get from the College of Physicians and Surgeons of Ontario. And it lays out in the front part sort of the new policies and regulations and expected standards of behavior. But everyone, of course, as soon as it comes in their mailbox, turns to the back part, which is where it details all of the complaints process. And you get to see who it was that got in trouble this past month. And those complaints processes are almost never about leaving a sponge in an abdomen or taking off the wrong leg in an amputation procedure. It's almost always about ethics and professionalism and about breaches of policies that have to do with those areas. And so physicians and other healthcare providers are very attuned to this concept of the importance of not just having an internal moral compass, which serves us in the majority of cases, but also understanding what sort of the expected standards are as well. Legislation, and this is something that's, again, we don't have a lot of sort of legislated procedures. Most of them are regulated, so we're not sort of subject to criminalization or going to jail if we do something wrong. But certainly, again, this idea of a federal law on assisted dying has caused us to really think about, am I following the legislation versus my professional standards? So it's made us a bit more, I think, sensitive to this idea of what does the law say, as well as what ethics says about some of these things. So I think healthcare providers are a little bit more in tune with legislation these days. And then we have, formal practice standards. So we have what our profession and others have set out and said, this is the standard clinically that you're expected to uphold. And of course, if you don't uphold that, there's an ethical component of that failure to uphold that standard as well. So there's all sorts of ways that we as healthcare providers sort of think about what's moral and what's ethical, right? And yet, in spite of this, in spite of all these documents and all these sort of codes and policies and regulations that we have, you're all still here today because we still struggle with, what's right and what's wrong. I'm going to talk a little bit about codification, and that's the CMA Code of Ethics on the bottom there. So most professions have a code of ethics, and this really sort of codifies expected standards of behavior. And again, most of the regulated professions have these in Canada. And it's really what I call sort of the practical actualization of often abstract principles that reflect moral standards of society. So we might talk, for example, in, let's say, in nursing about altruism. Well, what does that mean at the bedside? What does it mean to be an altruistic nurse at the bedside? What are the expected standards of behavior? Or we might talk in physical therapy of patient-centered care, putting the patient at the center. What does that actually mean in practice? So we try and use these codes of ethics or these standards to help us understand how we're going to implement these principles. And when people ask me what the difference is between bioethics and medical ethics, it's really this document. So bioethics is really sort of the collection of principles and of moral concepts as they pertain to biology and medicine. The actualization of those concepts is really this code of ethics to say this is what's expected when you go into the medical profession. And this is one of the things that really sets healthcare providers apart from other types of professions. Is you enter the profession declaring yourself as someone who will uphold the expected standards of behavior. There's not a lot of professions that necessarily do that. So these are really explicit statements of ethical standards. And while codes are the usual expression, I work a lot internationally, and I see a lot of prayers and oaths and creeds and statements. So it's not just codes. And I can tell you that those prayers and oaths and creeds and statements may look very different in, let's say, a Middle Eastern context or a Far Eastern context than they do in Western medicine, where so much of the focus is now on patient autonomy. And we're going to be able to connect that back to some of these conversations around assisted dying and team-based care and some of the challenges that we as healthcare providers face in a system that is so grounded in patient autonomy versus other systems in other parts of the world. So this is very contextual and based very much on the society in which we practice, right? So it's not it's not sort of a document or a code that stands alone from what the rest of society thinks. This is very much an interplay between the laws and the rules and the norms of society at large and how we as healthcare providers fit in that context. Does that all make sense? Okay. Stay with me. Organizations, physicians and other healthcare organizations have generally taken responsibility for writing their own codes, but other bodies, government, religious, and cultural, have also claimed some authority. And it doesn't take a lot of thinking to recognize the implications of that if we take away the right of us as professionals to set our standards and we give it over to, for example, government, that's going to look very, very different, right, than what we would establish as expected norms. And I'm going to give you a very specific example of that. And so disputes about who has the authority to do this really go a long way in terms of determining what those duties will be, whether it's healthcare providers versus member of the public or government. So, certainly in medicine, there's a lot of talk about this idea of professionally led regulation. So our regulatory bodies have a number of members of the public on them, but they are a majority of physicians. And it's the same for most of the other regulated professions, because we can best understand, although the presence of members of the public is very important, they don't always understand sort of the context or the expectations of being in that particular profession. So there are now lots of countries where this concept of professionally led regulation is being challenged. And I'm going to come back to this idea of, who it is that sets the standards and how government is involved in this with a very real example. So I was at a meeting 2 weeks ago with the World Medical Association, and they've just done a revision of this document called the Declaration of Geneva, which is very much, in many ways, the modern-day Hippocratic Oath. It's really a declaration of what we commit to as a medical profession. And a lot of our national medical associations around the world use this at the beginning of every meeting to say, this is what I commit to as a practicing physician. And as we were talking about this, some of the delegations from sub-Saharan Africa got up and said, look, this is all nice and good, but you need to understand that where we live, the government takes this document and it says, ha, 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 look, you said you're going to practice no matter what, so we don't need to provide you with things like hospitals or clinics or clean water or equipment or gloves or masks. You're going to do it anyway because you've got ethical standards. And so you need to understand sort of this cultural and societal context is very different depending on where you practice. So the unintended consequence for these physicians where they practice is to say, I will do this no matter what because I'm committed to the good of my patients. Well, that's being used against them. And so now, although the Declaration of Geneva itself didn't change, we are undertaking a body of work in those locations to help governments understand better what their responsibilities are. And I've done a lot of work with the WHO over the years on things like extreme drug-resistant tuberculosis, where healthcare providers are being asked to uphold their ethical standards, but they aren't being provided with the necessary safety equipment. So again, it's an interplay between those things. In Canada, the preeminent document is the CMA's Code of Ethics. So there are some countries where there are competing codes, and that makes things very complicated. We represent about 85% of physicians. We were founded in 1867, and so I know you're all really excellent at 1867 math these days. So this is also our 150th anniversary, and next year is the 150th anniversary of our very first Code of Ethics. So it shows you the importance of this issue to healthcare providers, that the first major document we produced as an association 150 years ago was a Code of Ethics to set the standard. As you can imagine, it's evolved a lot since that time. It was very physician-centric early on, mostly around obligations of patients to do what we told them and not question our expertise and wisdom. It looks very different these days. So really more of an elaboration of the moral obligations of physicians. And it's referenced by all Canadian medical and regulatory bodies as well as the court. So even though it's not a legally binding document, it really holds a lot of legal weight because it's something that the courts say, well, I see you didn't abide by the CMA's Code of Ethics, and that's the expected standard of behavior that you have. So for doctors, this really holds a lot of weight, and I know it does for other health professions as well for their codes. So if we're all good people, and we're all good people, and we all have a code of ethics, and we have regulations, and we have internal policy documents, again, why are we here? Why does moral disagreement amongst team members still exist? Well, one of the reasons, and I've certainly seen this in practice, is that no code or policy can possibly address or anticipate every clinical eventuality. So interpretation of a document can vary amongst team members. So one person might say, well, I think this section of the CMA Code of Ethics means this, and someone else can say, I think it means that. And I can tell you, when it comes to the assisted dying debate, a lot of people grabbed onto this concept of first do no harm, right? That's not part of the Hippocratic Oath, by the way. Everyone thinks it is. And so the people who were opposed to assisted dying said, well, assisted dying is harm, so don't do any harm. And the people who favored or wanted to support assisted dying said, well, the greater harm is suffering and angst and existential angst. And so, in fact, this code compels us to provide assisted dying because allowing people to suffer is the greater harm. So there's very few documents that are able to parse that in a way that apply very specifically at the bedside. So it's hard for us as professionals just to say, I'm going to apply the code to every single situation that I encounter. And I would say that this is really the big one, is that team members have different internal moral codes or compasses, and for their own individual reasons may embrace different behavioral norms. And it doesn't mean that I'm right and you're wrong, or I'm more ethical and you're less ethical. It means the way that I interpret these situations and the way that I think about what's right and what's wrong is slightly different. So, for example, team members might object to taking part in certain procedures or interventions even when they're accepted or embraced by other team members. And again, that doesn't mean that either one of these team members are right or wrong in their decisions or their actions. It means they have a different view on this. And again, some of the recent debates we've had have really forced us to have some difficult conversations about this. Now, by and large, thankfully, society still recognizes the importance of individual morality for healthcare providers. Well, most of society. And so I have seen some relatively shocking declarations from some people saying, really, doctors and nurses and therapists and others should just do what we tell them to do. If I want a certain service and it's not illegal, I should get that certain service regardless of the views of that healthcare professional. And if they don't like it, they should go into accounting. Now, that is definitely the minority view, but again, with the recent debate on assisted dying, it's surfaced and it's more out in the open. So this is something that we have to, as healthcare professionals, address. And we have to have this conversation with the public about what it means to be a healthcare professional and be an individual moral agent with our own views. And we have to, as well, as healthcare professionals, come to some sort of an understanding about what we do when those views are in conflict and what our responsibilities are regardless of that, and where sort of our ability to enforce our own moral codes, where that might or might not end. And those are some of the conversations that are taking place. So I'm going to turn the page just a little bit and talk about this issue of conscientious objection, because this is really core to a lot of the conversations that we have around sort of disagreement between members, is this concept of conscientious objection. So really, where this started is not in medicine or healthcare. It's really around people who didn't want to go into military service. We all know the famous example south of the border where someone used heel spurs to get out of wartime service. Even before that, people were saying, well, I have a very deep-founded moral abhorrence of war, and so I don't want to go. Well, maybe that wasn't necessarily the case. And so there was a lot of conversation about how are we going to determine who is and is not a true conscientious objector. So these objections could be based on religious conviction, moral, or ethical considerations. Does anyone know who the most famous conscientious objector was? Muhammad Ali. So Muhammad Ali, I love this quote, "This draft is about white people sending black people to fight yellow people to protect the country they stole from the red people." And I ain't got no quarrel with the Viet Cong. Hard to be more succinct than that. So Muhammad Ali really brought out this idea of, what happens when, so he converted to Islam, what happens when sort of our moral convictions, our religious convictions, come up against these issues of drafting, and you don't want to go to war because you have a strong moral conviction that killing other human beings is wrong. And this is really where the concept of conscientious objection originated. And Canada has a long history with this as well. So we've recognized conscientious objector status since the late 18th century. Now, it was really hard during the First World War, for example, to convince these military tribunals that their grounds for exemption were genuine and heartfelt. So they would go in front of these tribunals and they would say, I don't want to go to war because I have a religious conviction or a moral conviction. And the tribunal was, of course, trying to get soldiers to go fight for Canada, and they didn't really know what to do. So I'm going to ask you guys, and I'll give you a hint. This is really relevant to Saskatchewan. What did a lot of people say that they were during those war times? Farmers, right? Because farmers got an automatic exemption for military service. So lots of people said, that farming thing looks pretty good right about now, and got these exemptions as farmers rather than pacifists, because farmers could be excused from all forms of military service. So this is where sort of this concept of conscientious objection comes from. It's really around this sort of objection to fighting in wars, which makes a lot of sense. So how do we apply this in medicine and in healthcare? What does this mean in that sort of clinical context? So again, if we go back to the Hippocratic Oath, many centuries old, I will follow that regimen which, according to my ability and judgment, I consider for the benefit of my patients, and I will abstain from whatever is deleterious and mischievous. So it gives sort of this idea that healthcare providers can have an internal moral compass. What is for the benefit of my patients? How do I determine that? It doesn't say whatever my patients ask for. And what is deleterious and mischievous? Right? It doesn't sort of unpack that either. But it gives us a sense that it's up to healthcare providers, physicians, and others to interpret this and decide what's appropriate from this sort of moral standpoint in terms of patient care. So this goes all the way back to Hippocrates. So it's really the notion that a healthcare provider can abstain from offering certain types of medical care with which they don't agree. And this would include care that otherwise would be considered to be medically appropriate. So a very concrete example would be an obstetrician who refuses to perform abortions or sterilizations. So these are procedures that are available, they're legal in Canada, and some obstetricians would perform them, but some would say, this is against my own personal ethical views, and I won't do it. I'm conscientiously objecting to that. And here, these are two key paragraphs. So on the one hand, there's the argument that physicians have a duty to uphold the wishes of their patients, as long as they're reasonable and the service requested meets clinical standards. So this is the idea of healthcare provider or physician as technician. So we're here to provide a service. There's a menu of services that are available. You go into a McDonald's, probably one of the McDonald's that the founder of this lecture used to own, and you look at the menu and you say, I want this, this, and this, and those are the healthcare interventions that I want. And the healthcare provider says, okay, let's do that. There's another school of thought that says physicians and other healthcare providers themselves are moral beings, and morality shouldn't be infringed upon by dictates from the legislatures, the medical community, or patient interests. And I can tell you there's a real sort of battle going on right now between these opposing views. And a lot of people say it's a fight for the soul of medicine. Some of you in this room will know Nuala Kenny, who's a Catholic bioethicist and pediatrician in Halifax. And she's written and thought a lot about this issue, about this idea of the devaluation of physicians to the role of technician and the importance of maintaining this central concept of morality in medicine. Then there are others who say it's really the logical extension of individual autonomy. So I told you I was going to come back to that concept of autonomy in Western medicine and how it all ties into the debate that we're having currently. There's a lot of people who say, it's up to me, I have rights. I have this right. What we need to also recognize is that if someone has a right, someone else has an obligation. And that's where we often struggle as healthcare providers, is to meet that obligation in situations where we don't agree or we find the request to be morally problematic. So how do we approach this in practice? So here's a document by the College of Physicians and Surgeons of Ontario called Interim Guidance on Physician-Assisted Death. So in general, when it comes to this idea of conscientious objection or the idea that certain members of the team can refuse to participate, we've really left that up to the regulatory bodies. And so this is a really good example, this idea on assisted dying. So the CPSO, essentially in a nutshell, became the first organization in the world to require what they call mandatory effective referral. And what this means is that even if you are morally opposed to a procedure, whether that's abortion or assisted dying or sterilization or anything else, you don't have to participate. It's certainly your right to refuse to participate, but you have to refer that patient to another provider. Now, for a lot of physicians and other healthcare providers, that's not a problem. A lot of people, even if they won't do the service themselves, they will refer. But for a certain percentage, probably 5 to 10%, maybe a little bit more, they find that to be morally analogous to performing the procedure itself. And I think there's something to that. Because when we talk about a referral in medicine or in therapy or in other areas, what we're really saying is that I won't do this service myself, but I'll send you to a colleague who will do it, and I will endorse their intervention. So if I'm someone and I don't do hip replacements, but I'm sending you to an orthopedic surgeon, I'm saying I'm referring you because I think you need this procedure, and I think this is the right person to do it. So you can see why that could be problematic when it comes to things like abortion or assisted dying. So if I'm referring you, I know what the end outcome of that action is going to be. It's going to be the completion of that intervention in which I did not want to participate myself. And in many ways, I'm endorsing that by referring you. And so people who find this problematic, I think, do so for a good reason. And there's a court challenge against this policy. I don't know where it's going to end up, but it does seem to me to be somewhat unconstitutional, particularly since there's no evidence that it's rooted in the concept of patient access. And it is the only policy in the entire world that mandates effective referral. I'm just going to talk a little bit about assisted dying. I know there's been a lot of conversations around this. So the Carter decision from a couple of years ago found that the laws prohibiting assisted suicide and euthanasia were unconstitutional. But one of the remaining points of contention from a legislative and a regulatory perspective is this idea of conscientious objection and exactly what that means in the context of assisted dying. So this is a direct quote from the SCC decision. A number of the interveners asked us to account for physicians' freedom of conscience and religion. And it names some of them, expressed concerns that physicians may be obligated based on a duty to participate in physician-assisted dying. They asked us to confirm that physicians and other healthcare workers cannot be compelled. They would have the court direct the legislature to provide robust protection for those who decline to support or participate for reasons of conscience or religion. The Canadian Medical Association, we were one of the interveners, I was in the courtroom that day, reports that its membership is divided on the issue. It states that it will support the right of all physicians within the bounds of law to follow their conscience in deciding whether or not to participate, and it seeks to see that reflected in any legislation. And then the court said, and this was sort of the key wording that they used around this issue, nothing in the Declaration of Invalidity, which we propose to issue, would compel physicians to provide assistance in dying. And so people, most reasonable people, quite clearly read that as saying no one is going to force healthcare providers against their conscience to actually participate, which I think most people found quite reasonable. But they did say, we note that a physician's decision is a matter of conscience and in some cases religious beliefs. We don't wish to preempt the legislative and regulatory response. Rather, we underline that the charter rights of patients and physicians need to somehow be reconciled. And that's the situation that we're dealing with at the moment, is how to try and reconcile these things. And so again, it's the same when it comes to, so we're talking about physicians and patients, but we could equally be talking about physicians and nurses and pharmacists and therapists and any other member of the healthcare team, right down to administration, cleaning staff, anyone that has any sort of involvement in these types of procedures which they find problematic. We need to reconcile these different views that we hold as providers. We do have previous experience with this in the medical community that we've sort of looked at in terms of learning from past experience. So this issue of therapeutic abortion and the ways that healthcare providers have not handled it always as well as they could, which I think ultimately was the reason why the college in Ontario came down so heavy-handedly, is because of really awful stories about ways that physicians and others approached patients in these types of situations. Very small percentage, but very inappropriate types of behaviors. This idea of access to services. So over time, we've sort of developed a framework in Canada or a system in Canada where women who needed these services eventually knew where to go. Even if it wasn't formal and it wasn't publicized, they knew where they could go to get help. And this issue of referral was always kind of underneath the surface. And a lot of people were often surprised that physicians weren't required to refer. And there was a front page article in the National Post 10 years ago where we sort of help people understand the CMA perspective on this, and it engendered another sort of round of debate about this idea of referral. But until really we were forced to deal with it with assisted dying, we were able to, in many ways, sort of sweep it under the carpet. We came out during the assisted dying debate with a series of principles-based recommendations. So physicians are not obligated to fulfill requests. This means that they're not required to provide it, to participate in it, or to refer the patient to someone else. There should be no discrimination against a physician who chooses not to participate. However, and this is, I think, again, sort of an important part of the conversation, is physicians are still obligated to respond. So, for example, I met with actually some people from Planned Parenthood in the U.S. and other sort of abortion providers saying, here's the other perspective. And stories of doctors and nurses and other providers saying, well, if you get an abortion, you're going to go to hell, right? Or, slamming the door to their office or firing them from really egregious behaviors that none of us would ever accept. But, these things happen. And we really now needed to confront this issue of what if we disagree with this? Okay, we have rights, but what are our responsibilities? And again, this extends to this idea of how we relate to each other as healthcare providers as well. How do we respond to this? So we can't just say we're not going to talk about that. There's two equally legitimate considerations: the protection of freedom of conscience for physicians and the assurance of effective patient access to a medical service. So in order to reconcile these competing sort of concepts, we need to make sure that patients are provided with information and advise them on how to access any separate central information counseling and referral service. We're expected to make available relevant medical records to the attending physician or transfer the care to another physician when they request that. And physicians are expected to act in good faith, not discriminate against a patient requesting this, and not impede or block access to a request for assistance in dying. So much of this seems to be sort of common sense, but it wasn't ever codified, or we never laid out what the expectations were until we had this debate on assisted dying. And I've had personally a lot of meetings with people who feel very, very strongly about the concept of conscientious objection, and I think they've been very helpful for both sides, because I think physicians who feel very, very strongly in opposition to assisted dying have helped their members in some of these organizations understand what their responsibilities are, even if they don't participate. And I think that's really been a positive dialogue. This is myself and our president at the time, Cindy Forbes, appearing before a federal joint committee back in the day, and saying the CMA strongly recommends that physician freedom of conscience be recognized as a key component of the legislative response to Carter and a necessary measure to ensure pan-Canadian consistency. Now, there are limitations to conscientious objection. We can't just say, I don't like that, I conscientiously object to it, I'm not going to do it. We need to understand what those are. We have, as healthcare providers, a fiduciary relationship with our patient, where one party exercises power on behalf of another and pledges himself or herself to act in the best interests of the other. So our relationship, this healthcare provider-patient relationship, is understood as a fiduciary one, because sick patients are entrusting us with discretionary power. Because of this, we owe them duties associated with this relationship, like loyalty, good faith, avoidance of conflict of duty. And this means that there are limits to the right to conscientious objection. Some of them are really obvious, right? So some of them we'd look at and go, yeah, that just makes common sense. So male healthcare providers who say, I don't want to see a female patient, it's against my religion. We wouldn't accept that in Canada. Healthcare providers refusing to treat a patient with HIV because they don't condone their lifestyle or sexual preferences. That's not on either. I've actually seen newspaper headlines, healthcare providers refusing to wash their hands for religious reasons. So saying it's against, I don't even know what religion that would be. It's against my religion to wash my hands, but I'm just going to go into the next room and go ahead and do an intimate examination anyway. So we're not going to allow people to just sort of use a blanket sort of statement that I have X, Y, or Z view, and I can impose that on anyone at any time. More commonly, the issue that we deal with is this idea of how we present information. And this is really critical as well to this team context, how we share information between team members or how we treat each other in this context. So we know, based on the principle of autonomy and informed consent, patients have a right to receive accurate medical information. Patients don't have the knowledge that they need, and so we need to impart this knowledge to them in a way that doesn't curtail the patient's knowledge or exploit its limits. We also need to recognize that we need to be sensitive to the urgency of a request, and this plays some role as well. The more urgent the clinical scenario, the higher the expectation on the healthcare provider to intervene, even where they might feel morally compromised. You can't sort of give a blanket statement here, it depends on the case, but if someone's life is in imminent danger, you may have to set aside your moral views for the time being to save their life. The issue of assisted dying in rural and remote communities may challenge this concept, where people only have hours or days to live and there's no one in their community. What do we do then? And I really want to highlight the fact that, I alluded to some really bad behaviors by physicians in abortion. We need to make sure that when we're having these conversations, it's a way that is very compassionate and respectful. It should be a statement about the healthcare provider, not the patient themselves. Discussion should be compassionate, respectful, and in the first person. So something like, based on my own beliefs, I can't help you with that, but I can answer your questions, and I can give you information about its availability. I can point you in the right direction. So how do we approach this in practice? Disagreement is really common. It's rarely the result of a clash between codes or policies. It's almost always due to individual level differences of opinion or different moral perspectives. Very often, these perspectives are long-standing, profound, and they're not necessarily reconcilable. So it's not an issue, really, where we can go to arbitration or mediation and have someone say, well, you're right and you're wrong, so the wrong person, you have to do what the right person says. I mean, these are really things that we develop as part of our core belief. So it's not usually a situation where we have an opportunity to sort of get everyone on the same page. Often they're just irreconcilable, and sometimes we just have to be okay with that fact. Here's a document that the CMA produced along with the Canadian Healthcare Association, the Canadian Nurses Association, and the Catholic Health Association of Canada. And it's called a Joint Statement on Preventing and Resolving Ethical Conflicts. I'm just going to read a few paragraphs from it. So disagreement among HCPs about the goals of care and treatment should be clarified and resolved so as not to compromise their relationship. So before we go to the patient with a plan of action, we should be united as a team in how we're going to approach this. It's not helpful for us or for the patient to be at the bedside saying, I think we should do this, and then the therapist says, well, that's against my personal values. I mean, that's just, that's confusing and not very therapeutic. Healthcare providers should declare in advance their inability to participate in procedures that are contrary to values. They should not be subject to discrimination for acting on their beliefs, and the exercise of this provision should never put the person receiving care at risk of harm or abandonment. If they cannot support the decision that prevails as a matter of professional judgment, we should allow the healthcare provider to withdraw without reprisal, ensuring that the person receiving care is not at risk of harm or abandonment. There are other considerations. It's good to identify beforehand, and again, this debate on assisted dying has really forced us to do this, identify who is a willing practitioner and which healthcare facilities are willing to provide these services. And then try and put in place mechanisms that allow for accommodation of all views and also ensure patient access. So in Alberta, there's a 1-800 number that patients and families can call. There's always someone on the end of the line who will say, I can connect you with a willing provider for assisted dying. The physician or other healthcare provider can give the patient the phone number. They don't have to go look it up, and the patient can call. So it's a direct connection. Patient care doesn't suffer, but physicians aren't forced to refer a patient. And it's not a complex system, and it's not very expensive. There's other provinces that are looking at this, but Alberta's really been at the forefront. Don't be seen as passing judgment on other healthcare providers or on patients and their families. And I'll tell you, one of the things that has made me most proud of this sort of controversial issue and the way we've dealt with it has been the respect that physicians and other care providers have shown to each other. Because I think no matter which side of this debate you're on, you recognize why people feel otherwise. And there's been a really, I think, a tremendous amount of respect and compassion in these conversations. Conversely, the only public town hall I ever went to on assisted dying, one of the first things that happened was a member of the public punched a CBC reporter in the face. And so, not quite as respectful necessarily as what we've seen at the healthcare provider level. So we need to make sure we keep that in mind. We're not here to tell people what the right or wrong thing is. And then this idea of transition or transfer of care, which I know is an issue that a number of facilities are dealing with. Both parties, in terms of the healthcare providers, those who participate and those who don't, have to be respectful and mindful of the views of the other party. And I think it's really important that we remember that there's rarely an absolute right or wrong, but there's lots of shades of gray. But in almost every one of these situations, there's a vulnerable patient who needs our help and compassion. And this is, of course, why we all went into our fields anyway. So to summarize, differences of opinion arise on a regular basis. Lots are moral in nature. Sometimes codes and policies can be helpful, but in a lot of situations, the differences will be individual, personal, and deeply held. The recent debate that we've had in Canada on assisted dying has really forced us to confront this in a way that has tried to respect individual conscience while making sure that we don't compromise patient care. It's forced us to have some of these difficult team conversations where we may not agree with our colleagues, but we try and be respectful in the way that we have those disagreements. The concept of conscientious objection is very complex and controversial, and some believe that healthcare providers have an absolute obligation to provide the services. Others feel that they have a right to act on their deeply held beliefs and convictions. There is no universally accepted approach, and I said this at the beginning. There are no black and white answers to this. No universally accepted approach that will resolve all moral disagreements. But what the debate around assisted dying has taught us is the importance of respect, open discussion, clarity around obligations, and the need to try and set in place where we can systems that will accommodate for all different types of views while also ensuring patient access. But at the end of the day, a lot of us are like Homer. We struggle with what's right and what's wrong, how to reconcile the different views that we have, and we're all sort of doing the best that we can in a very complex situation. And I think we need to remember that. If you're dealing with someone on your team who has a different view than you are and you feel like you're really struggling, they're probably really struggling as well. So this idea of open and compassionate dialogue and communication is always very important. Thank you very much. I have a few minutes for questions, as promised. It's also lunchtime. I recognize that, too. Hi. Yeah, it's a great question, and that's really, I think, in Canada right now, one of the really complicated parts of this equation. Seems to be working reasonably well in more urban locations. Manitoba, as some people know, have sort of an assisted dying team that can travel around the province to an extent. One of the one of the really unique things about that area is that if you're in a remote community and you need, let's say, some specialized cardiac procedure, you can come to Saskatoon or Regina and get that and go home. Assisted dying is a little bit different. It sort of defeats the purpose if you have to travel to Saskatoon for assisted dying and be far away from your friends and loved ones, which is what a lot of people want assisted dying for, is to be surrounded by people that they care about during the time. And there's no easy answer. What I think we may see evolve may be sort of traveling clinics or practitioners who are willing providers. I have heard, for example, in British Columbia, a number of practitioners going out to the islands, right? So it's not a perfect scenario, and generally they're not necessarily even reimbursed for these things. A lot of them are sort of doing it at their own expense, but we might be able to come up with a system. So they have something like this in Holland, which admittedly is quite a bit smaller, where they do support physicians and providers who are willing providers who will go and travel to where the patient lives. And I think in a geography like Saskatchewan, that might make more sense, because you're absolutely right. It's very difficult if you're in a very remote community. The physician doesn't want to participate. A 1-800 number is of little consolation if there's no one that will come to where they are.
Can I just make... Oh, sorry. Go ahead.
Go ahead, Lillian. Did you want to add to that?
I was just going to add to that specific comment. So in Saskatchewan, people are generally going through the equivalent of practitioner staff affairs, and rural areas are being served by physicians from other areas, including other health regions. So it's obviously not ideal, but it's infinitely better than trying to force some physician who is obviously very distressed about this to participate, and I think none of us would believe that should be the case. But we are looking in the province at having a province is becoming one health region, and there will be likely medically assisted dying committee for the whole health region that then is currently in the process of looking at how that will be, and that there likely will be one phone number.
Okay. Right. Yeah, and I think more and more provinces will move to that because it is working well where it's been implemented.
Thank you. Very interesting talk. I guess I just wanted to, although I'm a big supporter of conscientious objection and the right for physicians to, as much as is possible, to follow their own moral compass. I guess I would challenge your perspective about that referring someone or ensuring that someone has access to a physician for a publicly funded, medically appropriate procedure is reasonable. Because I think that in a publicly funded healthcare system where patients are asking for something that is very reasonable, you aren't really just a technician, you're a gatekeeper to access to that. And I would say that a 14-year-old girl who comes to your office seeking an abortion and you turn her away without facilitating anything for something that's legal, whether you agree with it or not, can make that person who's very vulnerable have difficulty with access, which is quite different from someone who's 35 and maybe a confident individual and seeking the same thing. I would also challenge your perspective that it's obvious to all of us that not wanting to see a female patient or not dealing with, say, a homosexual couple we all see that as black and white and reasonable. I think that's a very Eurocentric perspective, and we have a lot of immigrants now who may not see that. And so I think that, for example, if you're an atheist and you don't have a strong religious perspective at all, you may think that abortion, which is a legal medical procedure in our country, should be easily accessible, and it's a no-brainer, and why should you be allowed to refuse to do that? So I think that conscientious objection is reasonable to a point, but patients in our system are dependent on us as physicians to access legal medical care.
Thanks for those comments, and I'm always happy to be challenged. Just so I'll clarify both of those points. So, the situation that we've had for assisted dying was very much, as you say, where we really didn't have any sort of guidelines or a framework for how physicians or other healthcare providers would react when they did conscientiously object to a service. And there really weren't many very clear sort of professional regulations either. Certainly nothing requiring referral, but even nothing really outlining what their responsibilities would be. And so to me, one of the really beneficial aspects of this debate has been the opportunity to, in some ways, help that community of conscientious objectors understand that they do have responsibilities. And ultimately, it's this idea of ensuring patient access while also respecting different views of conscience. And that's really been sort of our focus. And so, if you were to, say, in Canada, somehow be able to prove that physicians not making a referral was impeding patient access to a service, I would say you would then really have to have a strong look at that. The good news is it's actually a false dichotomy. It's not conscientious objection or access. You can have both. The challenge, exactly as you sort of outlined it, is putting in place a system or helping every healthcare provider understand their responsibilities in a way that will ensure access. So the example of a 14-year-old young woman is an excellent one. So if I'm a doctor and I just say, you're on your own, that's not good enough, right? So one of our challenges is what's between that's not good enough and full referral to make sure that we can respect the views of the healthcare provider while also making sure the patient can access that. Is that a 1-800 number? Is that a pamphlet for a clinic down the street? It probably depends, right? But it's certainly not a closed door or a moral condemnation. So we're really trying to be able to accommodate everyone's views on this. And around this idea of sort of cultural context, and I'm very sensitive to that, I think the examples I tried to use were really things that are almost human rights types of situations, right? So where we recognize that you can't discriminate against someone in Canada based on their sex or their religion or their sexual orientation if you're going to practice medicine in Canada, right? So absolutely, those things might be very different for different types of providers or different types of patients, but we have a certain sort of expectation in Canada where if you're going to be a provider in the system, in the public system, or a patient in the system, then you're expected to adhere to at least sort of a common set of standards. Now, we struggle all the time with, I see it all the time, with immigrant families who come in and they say, I don't want a male doctor, right, for example. And we try and accommodate those. I mean, I hear stories all the time about how, the team does everything they can to try and accommodate those preferences. And I think we tend to be fairly flexible. But, to your point about being sort of publicly paid employees in the healthcare system, I think the standards for providers in that regard are probably higher. So thanks for those points.
All right. Well, thank you for a wonderful presentation. I noticed a lot of what you said was maybe a bit more directed towards physicians than some of the other members of the team. Fair enough, coming from the CMA. I wondered if you maybe had any advice for how to function more as a team, knowing the power dynamic, the imbalance that often exists between physicians and nurses, sure, occupational therapists, the whole group. Maybe you could just provide a bit of reflection. Sure.
Yeah, if I had an answer to that, then I wish I did. I think. So I'm a rehab medicine specialist, and so everything I do is team-based. And some of my old team members are here, and I think they can attest to the fact that it's a pretty flat hierarchical structure in that sort of milieu, and I think it's a good model, for other areas. One of the things that we've struggled with as a profession over the years is we've moved, I alluded to the fact that the old code of ethics used to be all about, why patients should do everything the doctor says and just listen to us. Certainly we felt that way about team members as well, right? And the relationship, for example, between, medicine and nursing was very, very hierarchical and very, I think, patriarchal as well, and unfortunately a lot of situations. I think we've seen an evolution in that regard, but you can understand why, as a profession, it would be difficult for some doctors, maybe particularly doctors who have been practicing for a number of years, to see a change in that, because having sort of authority over decisions and then an evolution to having shared decision making is challenging, regardless sort of who you are when you're used to one system. And I think the other challenge that a lot of doctors have is this concept that at the end of the day, it may be the physician who's ultimately accountable or responsible from a medical legal standpoint for care. And along with that goes, sort of the responsibility of making those decisions. I think what we're seeing, and I hope I'm right, is a move towards, as we look at patient-centered care, a move towards much more team-based care as well, and recognizing the different sort of complementary skills rather than sort of where we are in the pecking order that we all bring to the table. And so, physicians have certain skills that they're trained in around sort of diagnosis and physical exam and intervention. A lot of therapists have very complementary skills, nurses as well. Pharmacists bring important things to the table, social work. I mean, I could go down the list. And I think, I hope what we're seeing is a recognition that that all of those are really important for patient-centered care. And so, while we could debate for a long time who's the leader of the team or the captain of the team, whether that's the doctor or the nurse or the social worker or someone else, or maybe it depends on the context, I think what we're seeing is a flattening out, at least, of this idea of physician sort of as all-knowing or as the one who makes all the decisions. Happy to be challenged on that too, though. Lunchtime.
Almost. Are there any questions from telehealth sites today? All right. Well, then, on behalf of St. Paul's Hospital and the St. Paul's Hospital Foundation, thank you very much for joining us today, and please join me in thanking Dr. Blackmer for this.